A very good morning, respected Emeritus Chairperson Dr. M.L. Swankar sir, Medical Director Dr. S.S. Jaiswal sir, distinguished faculty members, my seniors, colleagues and juniors. It's always an honor to present the department here in CCR in front of this August gathering. The Department of Critical Care Medicine was started in 2017 and it is the largest critical care unit in the state of Rajasthan, where we are trying to provide the international standard of care to our patient. In the hospital, there are 300 critical care beds including various ICUs and HDUs, out of which 92 critical care beds are directly managed by Department of Critical Care Medicine. And the daily workload, always there is more than 80% bed occupancy, sometimes it is 100%, and it is very difficult to get beds in that department. And this is the team critical care. We have 2 professors, 1 associate professor and 3 assistant professor in the department. And I am very thankful to our Emeritus Chairperson Dr. M.L. Swankar sir and the management of Mahatma Gandhi Hospital for providing us the world-class infrastructure along with the ultra-modern equipment for the care of our patient. We have 5 ECMOs and 2 CRRT machines, and so far we have done 25 ECMOs and more than 250 CRRT sessions for our needy patients. It is always good to provide the quality indicators. The data which I am showing you here is taken from the Hospital Infection Control Officer and the Quality Department. The first slide is showing the various hospital acquired infection rate in the ICU, including the CLABSI, COTI and VAP rates, which is as per the NABH standards. And second one is showing the standardized mortality rate, which is 0.53 throughout the year in the Department of Critical Care. Any SMR which is less than 1 is considered good. It shows the quality treatment which you are providing in the department. This is about the courses which is run by our department. In 2021, the DM Critical Care course was commenced. It is recognized by NMC, and we have 7 DM Critical Care students with us. Apart from this, we are running diploma courses for doctors as well as nurses. Some of our students have received awards and appreciation when they present oral and poster presentation in various state conferences and in some of the state level sports tournament. So far we have published 43 research papers in index journals and 11 ongoing projects, out of which 3 have already accepted to be published in the PubMed index journals this year only. Our team members are a regular faculty member for the national conferences and some of the international conferences, and we have credit of writing some chapters in the books. I especially mention Dr. Ravi, who has written 9 chapters in the various books of critical care medicine. We are a part of Jaipur Swasthya Charcha and Jaipur Videsh Parcharya, and we are regularly organizing various conferences such as POCUS, USG workshop, ECMO and CRRT workshop, Antimicrobial Stewardship Symposium, End of Life Care workshops. Other services which we are providing in the hospital is Code Blue services. In collaboration with Department of Anesthesiology, we cover whole hospital, and if you see these 2 charts, we are able to maintain the international standards in providing resuscitation of cardiac arrest patient. Similarly, we are providing critical care outreach team. It is a phone number. If you need anytime help of Department of Critical Care, you can call on this number. We will reach there to that particular bed. We are also providing end of life care facility with the collaboration with the Department of Pain and Palliative Care Medicine. Our faculty members are deeply involved in training and teaching and providing value-added courses such as BLS, ACLS, ATLS, and ATCN to our residents, doctors and nurses. And we are also providing mass training programs. In such 35 sessions, we have trained more than 2,200 students of various colleges, schools, factory workers about the BLS. We have received various awards and appreciation for our exemplary work in the field of critical care medicine as well as in the COVID pandemic. And as there is always a scope of improvement, sir, we request you to provide more manpower and more equipment and some more area for the extension of critical care services. Yes. And now I invite Dr. Sankalp Rajan. He is a first year DM resident for the start of case.
Thank you, sir, for providing me with the opportunity to present this case. So I'm Dr. Sankalp Ranjan, first year DM resident from the Department of Critical Care Medicine. Good morning, respected dignitaries, faculty members, and my dear colleagues. So I'm presenting a case of a 35-year male with fever and anemia. So a 35-year male, software engineer by profession, native of Chandigarh, Punjab, currently residing in Alwar, presented on 8th of September 2024 with the chief complaints of fever from the past 2 weeks, decreased urine output from the past 6 days, and severe shortness of breath on mechanical ventilatory support from the past 7 days. The history was given by his wife. Going through the treatment history, on day 1, the patient had fever, which was documented at 101 degree Fahrenheit, which was remittent in nature, along with generalized body ache, vomiting, which was treated as acute febrile illness by a private practitioner at home. On day 4 of the illness, due to ongoing fever, blood in stools and vomiting, and low platelet count, he got admitted to a private hospital in Jaipur. On day 5, he presented with blood in urine and jaundice. On the day 7th of illness, he developed shortness of breath and was started on non-invasive ventilation. On day 8, he developed decrease in the urine output and had a high colored urine, for which hemodialysis was initiated. 2 cycles of hemodialysis was completed till 7th of September 2024. And on day 13, the patient was intubated and placed on mechanical ventilation. The medication history for the patient received chloroquine, aceclofenac, and paracetamol by the general physician at home, and he was given injection meropenem, doxycycline, paracetamol, and pantoprazole at the previous institute. There was no significant past history, family history, personal history, or drug allergy history reported by the patient's family, and there was no history of blood transfusion. So these were the investigation trends from the previous institute, and one highlighted in the red are the investigation on the day the patient was received to our institute done in the previous hospital. The complete blood count showed severe anemia and thrombocytopenia with persisting trend and developing leukocytosis. Kidney function tests revealed elevated creatinine levels and azotemia with worsening trend, indicating acute kidney injury. Liver function tests showed hyperbilirubinemia and mild elevation in the liver enzymes, suggesting mild liver dysfunction. This is the investigation which we received on day. This was the investigation which we received the patient to our hospital. So investigations from the previous institute also had ABG, which showed mixed respiratory and metabolic acidosis with a lactate levels of 4.2 millimole per liter. ECG showed sinus tachycardia. Upper GI endoscopy was done on day 6 of the illness, which revealed erosive gastritis. 2D echo was normal. Viral markers were negative. HRCT chest was done, which revealed mild bilateral pleural effusion, left more than right, and atelectasis of the basal segments of the bilateral lower lobe. Investigations for fever were done, which revealed positive for dengue NS1 antigen and positive leptospira serology for IgG. Urine cultures showed growth of Enterococcus faecium species, which was vancomycin resistant. So there were 2 pending investigations from the previous institute. One was the blood culture sensitivity and the other was the G6PD analysis report. So this was the HRCT showing bilateral pleural effusion with in the left more than right, and atelectasis of the basal segments of the bilateral lower lobes. ABG revealed mixed respiratory and metabolic acidosis with a lactate levels of 4.2 millimole per liter. So the patient was referred to Mahatma Gandhi Hospital and admitted to our ICU on day 13 of the illness at 10:30 p.m. This marks day 0 of the admission in Mahatma Gandhi Hospital. So on general physical examination, the patient was sedated, intubated, and on mechanical ventilation with a temperature of 97.8 degree Fahrenheit, pulse rate of 106 beats per minute, blood pressure of 154 over 96 mm of Hg, SpO2 of 94% on 50% FiO2, on volume control mode, PEEP of 5 centimeters of water and a respiratory rate of 24 per minute. Pallor and icterus were present. There was no signs of cyanosis, clubbing, lymphadenopathy, sacral or pedal edema, and there was no apparent external mucosal or overt bleeding. So we carried a systemic examination. On CNS, the patient was sedated on fentanyl infusion. The pupils were bilaterally reacting to light, 3 mm equal. On cardiovascular examination, the S1, S2 were present and there were no added sounds. On chest, on respiratory examination, the patient was intubated and on mechanical ventilation, bilateral equal air entry was present and there were conducted sounds. On abdominal examination, the abdomen was soft, non-tender, with no organomegaly. The patient was catheterized with Foley's catheter, which showed dark colored urine. So on arrival, the patient had hemodialysis line in the right internal jugular vein, central line, arterial line, endotracheal tube, nasogastric tube from the previous institute. So summarizing the entire case, this was the summary. 36-year-old male with high-grade fever from the past 2 weeks, decreased urine output, respiratory failures, having who was intubated on mechanical ventilator, showed pallor, icterus and dark colored urine with the following investigation showing anemia, thrombocytopenia, leukocytosis, acute kidney injury with hyperbilirubinemia, dengue NS1 and leptospira IgG was positive. Urine cultures showed growth for Enterococcus faecium, and the imaging with HRCT showing mild bilateral pleural effusion with basal atelectasis. So, question to the audience and my colleagues. So, what can be the provisional diagnosis at this point?
MD residents? Third year MD कोई है? MD medicine? Yeah, so anybody can volunteer. कोई ना कोई तो होगा smart, bright guy or girl.
Hemorrhagic fever.
Can you stand up, please? Stand up, please. Yeah. Go ahead.
Dengue, hemorrhagic fever, chikungunya.
A whole bunch of viral hemorrhagic fevers. One is that possibility. Why did the patient go into renal failure? That's one possibility.
Sepsis, urinary, cancer-related bloodstream infection.
Right. So many lines are there. So many foreign material is there. Okay. Very good.
So we made a differential diagnosis of dengue hemorrhagic fever with multiple organ dysfunction syndrome with suspected leptospira co-infection. So what can be the differential diagnosis here? So yes sir.
Why not severe dengue? Because as per WHO classification, the latest है उसके हिसाब से it cannot be dengue. It cannot be dengue hemorrhagic fever only. Patient has presented with multi-organ dysfunction.
Sir, in severe dengue, like in dengue shock syndrome or severe dengue, sir, there is capillary leakage, and our patient was hemodynamically stable with on no vasopressor supports, so that can be. Sir, but that can also be in sir dengue with. Yes, sir. Severe capillary leakage is there in dengue shock syndrome. We also kept that in a possibility, but sir, because he was not into shock, so we didn't go with dengue shock syndrome. We kept it till dengue hemorrhagic fever as he was showing some warning signs also for dengue. So the differentials at this point we divided it into infectious and non-infectious causes. So we kept tropical fever syndrome, in which there can be dengue fever, malaria, scrub typhus, typhoid, leptospirosis, chikungunya and Zika virus. In bacterial sepsis can be one of the possibilities because the patient had many indwelling catheters, so it could be a vascular catheter related bloodstream infection, and it could have been urinary tract associated UTI also. and there can be many fungal infections also. So in non-infectious causes, we kept hemolytic anemia. It could be autoimmune or drug-induced, as the patient received chloroquine when he was treated outside. We kept idiopathic thrombocytopenic purpura as one of the causes, and one thrombotic thrombocytopenic purpura as one of our differentials. So moving forward, as critical care physicians, we encounter the first question, which mostly the attendants are what is the probability of the patient surviving. So at 24 hours of admission, we do an Apache score. It is the acute physiology and chronic health evaluation score. So it has 5 clinical parameters, that is temperature, mean arterial pressure, heart rate, respiratory rate, and Glasgow Coma scale, and severe lab parameters. So the total score, Apache score of our patient was 21 points, and it estimated a mortality of 38.9%. So we send the routine investigations like CBC, LFT, RFT, serum electrolytes, PTINR. Chest X-ray was done, ECG and ABG was sent. We sent paired for microbiology investigation and follow-up for sepsis. We sent paired blood cultures, urine routine microscopy and culture sensitivity, ET secretions for gram stain and culture sensitivity. We also sent an influenza panel and tropical fever PCR panel to rule out the co-infections. So for additional workup for hemolysis, we sent serum LDH levels, peripheral blood smear for hemolysis and parasites, and serum CPK levels. So coming to the management part, we initiated him, the patient was on ventilator, so we initiated the lung protective ventilation strategies according to the international guidelines. Empirical antibiotics were started, injection meropenem 1 gram IV 8 hourly, injection doxycycline 100 mg IV 12 hourly, and injection teicoplanin 400 mg IV 24 hourly. Injection pantoprazole infusion was started at 8 mg per hour. ICU care bundles were followed, and consultation for hematology and nephrology department were taken. So this is the ICU care bundle which we follow in every patient who is admitted in our ICU. So it has a mnemonics of fast hugs bid. So this is the basic care we do to all the ICU patients. So these were the investigations trends which were from on day 1. It showed severe anemia, leukocytosis, thrombocytopenia, creatinine of 5.2 with an urea of 191, and we received some reports that were pending. That was the microbiology panel blood culture that came to be sterile from the previous institute, and urine culture sensitivity, which was sent from our institute, showed growth of Candida species with a urine pus cells of less than 5 cells per high power field. The tropical fever panel came, which showed positive for dengue RNA virus, and rest all were excluded. So this cleared many doubts regarding the chances of co-infection, and thrombocytopenia and multi-organ dysfunction syndrome can be attributed to delayed dengue virus clearance. The previous institute report for G6PD activity came to be low with a value of 3.4 units per gram of hemoglobin. So at this point, I like to call my fellow colleague from the Department of Hematology, Dr. Gaurav Oja, to take us forward with the case.
Thank you, Dr. Sankalp. Good morning, everyone. So we received hematology reference in view of red colored urine and bicytopenia in a 36-year-old male with no comorbidities, whose provisional diagnosis is G6PD deficiency, dengue hemorrhagic fever with sepsis, multiple organ dysfunction syndrome, acute kidney injury on hemodialysis. So possibility of acute intravascular hemolysis leading to hemoglobinuria, anemia, renal failure secondary to antimicrobial treatment, and thrombocytopenia could be related to dengue fever, superimposed sepsis, disseminated intravascular coagulation, and thrombotic microangiopathy. So when approaching this kind of patient, initial baseline workup involves CBC, PBF, that is peripheral blood film, reticulocyte count, serum LDH, LFT and RFT. So as we can see from the CBC report, this patient who has anemia with a hemoglobin of 7.6 gram per deciliter, MCV of 96 femtoliter, leukocytosis with TLC count of 15,100 per microliter, and thrombocytopenia with a platelet count of 88,000 per microliter. PBF showing normocytic normochromic RBC with neutrophilia and thrombocytopenia with platelet clumps. So absolute retic count in this patient was 10%, corrected was 5.2%, total bilirubin was 5.6 mg per dl, direct was 2.1, indirect was 3.5. LDH was increased, that is 1440 units per liter. Creatinine was also high, 5.2 mg per dl. Since the patient was having red colored urine along with anemia, so to check for the cause we need to do further workup like PTA, PTT, fibrinogen, MGUMST test and fresh G6PD assessment, as the patient was not giving any history of previous such episodes. And urinary hemosiderin test. PT INR report was 11.5 seconds PT, INR was 1.017, APTT was 31.5 seconds, fibrinogen was normal 250 mg per dl, DCT was negative, G6PD qualitative, which was repeated in our institute, the report came out to be deficient activity. Urinary hemosiderin test was positive for hemosiderin. So as the PT APTT was normal, so and fibrinogen was also normal, so DIC was very unlikely, and TMA was also unlikely because there was no cystocytes in the peripheral blood film. So the final diagnosis is G6PD deficiency, renal failure which is multifactorial and is contributed by hemoglobinuria as well as underlying sepsis. Thrombocytopenia is also multifactorial and is contributed by dengue fever and underlying sepsis. So some words about G6PD deficiency. G6PD deficiency is the commonest RBC enzymopathy. Its prevalence in India is around 8.5%. In North India, it's around 23%. In South, it's around 18%, West up to 30%, and East up to 27%. G6PD gene is located on X chromosome and its inheritance is X-linked recessive. It has a variable presentation either as an episodic hemolysis or chronic hemolysis.
These numbers correct? 30%.
Oh. Okay. Sir, actually the study conducted in a small group of population in East, in West, and the overall means the 1-2 study which given the result of overall okay. So drugs that can trigger hemolysis in G6PD deficient individuals are antimicrobials like primaquine, analgesics like acetanilide, sulfonamides like dapsone, quinolones like ciprofloxacin, norfloxacin, moxifloxacin, other antimicrobials like nitrofurantoin, and other drugs like niridazole. So advice from the hematology department is to avoid the culprit drugs, strict input-output monitoring, monitor of the recurrence of the hemoglobinuria, management of underlying sepsis, transfusion SOS, vitamin B12 and folate replacement, family screening and genetic counseling, and nephrology consult for renal replacement therapy. Thank you so much. Now I will hand over the mic to Dr. Tanmay from the Department of Nephrology to take forward the case.
Thank you, Dr. Gaurav, and thank you, Department of Critical Care, for the nephrology reference of this patient. First of all, very good morning to respected faculties, teachers, seniors, and my colleagues. So, at this point, we are very much familiar with the case history of this patient, which has been briefly described by Dr. Sankalp initially. So, I, Dr. Tanmay Wagh, third year DM resident from the Department of Nephrology. So, after the making of primary provisional diagnosis of this patient as a dengue hemorrhagic fever with sepsis, with multiple organ dysfunction syndrome, with acute kidney injury stage 3 on hemodialysis, suspecting the etiology of mainly suspect pigment-related nephropathy in the background of G6PD deficiency. And the nephrology reference has been taken mainly for the decreased urine output, worsening renal function, dyselectroitemia, and the metabolic acidosis. So let's start. There are few questions for concern regarding this patient, mainly the relation of dengue and AKI. So we all know that the AKI has been divided mainly into the pre-renal, renal, and the post-renal part. And the dengue involves the kidney mainly pre-renally, causing AKI, and the intrinsic renal AKI. There is pigment-related nephropathy. We will see in the next slide that what it is. And how to manage this type of patients, mainly we will go for the supportive therapy, fluids, soda bicarbonate, and the antibiotics, whether it is empirically or the culture proven antibiotics. And we will going to dialyze these patients mainly into the state of hyperkalemia, metabolic acidosis, or the oliguria or the anuria. And how we'll see that how to proceed in this type of patients, mainly in the ICU care settings. So this photo mainly shows the pathophysiology of the pigment-related nephropathy, or we can call as a hemolysis-driven renal inflammation. We can see that in the sustained or persistent hemolysis, mainly in the background of the G6PD deficiency, along with the dengue virus infection, it causes the heme breakdown, and the products of the heme, mainly the iron, will go and deposit into the kidney tubules, which causes the mitochondrial damage, along with the accumulation of the pro-inflammatory cytokines and the complement levels, which causes further renal damage and the tubulointerstitial inflammation. So there are three modalities of the renal replacement therapy, mainly the intermittent hemodialysis, the slow low efficient dialysis, and the continuous renal replacement therapy. So we are using intermittent hemodialysis mainly in the hemodynamically stable CKD patients, and in the ICU care setting we are using SLED or CRRT. But as the cost effectiveness of the SLED, we have chosen this modality in our patient. So basically what we have done, or what we have did in this patient, so we have ensured adequate fluid management and by assessing volume status of the patient daily by doing the point of care ultrasound in nephrology. We have done the hygienic management of the hemodialysis catheter line and the pots to prevent the secondary infection, which is also known as a catheter related bloodstream infection. And we have done slow low efficient dialysis in this patient alternate day. We have ensured to give nutrition at least 30 kilocalorie per kg per day, and the protein supplementation of around 1.3 to 1.5 gram per kg per day to prevent catabolism, as already the patient in the hypercatabolic state, and even the 5 to 7 gram of protein loss can occur in each sessions of SLED. We have advised to don't change any type of antimicrobial therapy or dosages from our side. We have ensured that the patient should not be given any nephrotoxic drugs. We have advised to continue the supportive ICU care along with the short-acting sedatives according to the critical care team. And we have advised for the alternate days, complete blood count, renal function test, serum electrolytes, and the blood gas analysis. So this is the basic management we have done in this patient in the ICU care setting. So what progression we have seen in this patient? So the progression from the day of admission till the 20th day, the day of discharge, we have done the 8th session of SLED alternate day till 16th day, and the 2 sessions of conventional hemodialysis on the 18th and 20th day. So we can see here that the renal function is improving slowly by the blood urea level and the serum creatine level, and even the urine output was also improving, also has been improved from the 7th day of admission, which was at the initial it was less than 100 ml per day, which has been improved at least around 150 ml per day at the time of discharge. So mainly we have done this management in this patient, and now I'd like to call Dr. Sankalp again to proceed further. Thank you.
So thank you, Dr. Tanmay. Taking forward the case, so the progression from day 1 to day 3, the patient was intubated, but the FiO2 requirement came down to 30% with a PEEP of 6. The urine output was the patient was still oliguric. One session of SLED was done with one PRBC that was transfused. The hemoglobin was stabilizing, and we can see there was a gradual rise in the hemoglobin levels with a gradual rise in the thrombocytopenia also. So on 72 hours, we did a sequential organ failure assessment score, and it came out to be 10, which was 12 on the day of admission. It came down to 10, and it predicted a mortality of 50%. So the problems we gave the patient spontaneous awakening trial with sedation vacation and spontaneous breathing trial, and serum procalcitonin was sent as we planned for de-escalation of antibiotics. So the event that occurred on day 3 were that the patient was not easily arousable after sedation vacation. The GCS was E2 VT M5, which was low, and he had an episode of abnormal jerky movement. So MRI brain was requested from our side, and neurology reference in view of altered sensorium with a query seizure activity was given. So I would like to call Dr. Neha Sharma, third year MD resident from the Department of Radio Diagnosis, to explain the slides of MRI.
Good morning, everyone. MRI brain was done. These are the sequences. The first and second image show T2 weighted and flare images, axial sections. Here we can see there is no abnormal hyperintensity in the capsuloganglionic region or anywhere in the brain parenchyma. This is the SWI sequence, susceptibility weighted imaging. Here we can see there are no microbleeds in the brain, indicating there was no hemorrhage in the brain parenchyma. These are the ADC map and DWI sequences, which show no abnormal diffusion restriction in the brain. Sir, apparent diffusion coefficient, and yes, sir. These were the T2 and flare images. Here we can see there is this is the mesial temporal lobe, both the sides. We can see there is no evident hyperintensity or any sclerosis evident in the mesial temporal lobe, ruling out any evidence for epilepsy. So overall, there was no significant abnormality in the MRI brain findings. Now I would like to call Dr. Anush Jain for neurology consult.
Thank you, Dr. Neha, for your valuable input. Good morning, everyone. I am Dr. Anush Jain. I am Dr. Anush Jain, first year DM resident, Department of Neurology. This case was referred to us in view of altered sensorium and one episode of abnormal jerky movements involving all 4 limbs, which most likely was one episode of generalized tonic-clonic seizure. Neurological examination revealed that the Glasgow Coma scale was E2 VT M5. Bilateral pupils were 2 mm equal and reactive to light. Tone was decreased in all 4 limbs. Power, the patient was spontaneously moving all 4 limbs, but detailed examination could not be assessed. Deep tendon reflexes, bilateral biceps and triceps were +2. Supinator knee and ankle reflexes were absent. Bilateral plantars were flexors and neck rigidity was absent. So based on the history and neurological examination, 3 possibilities were kept. First was the possibility of metabolic encephalopathy. The second one was dengue encephalitis, and the third was acute vascular event, either bleed or an infarct. And in such patients with dengue and thrombocytopenia, ICH or bleeds are much more common. But the MRI already ruled out the bleed, so we moved forward with further investigations, and EEG was done. The EEG was suggestive of low amplitude theta waves with superimposed muscle artifacts, and this is very typical of metabolic encephalopathy, as there is generalized slowing of waves. So after EEG and reviewing the MRI, the provisional diagnosis of metabolic encephalopathy was made, and for the treatment, the patient was started on anti-epileptics. The injection levetiracetam was started 8 hourly, 500 mg. And the patient was advised for continuation of antibiotics for sepsis and the correction of metabolic parameters, as he had deranged RFT and LFT. So now I would like to invite Dr. Sankal to move further with the case.
Thank you, Dr. Anush, for your very valuable inputs. So carrying forward with the case, the events that we encountered on day 4 to 6 was that the urine output gradually increased, but it was still anuric with 70 ml per day. The sensorium had improved with E3 VT M6. we again gave spontaneous awakening and breathing trials, which failed in the previous 3 days, and there was generalized weakness with an MRC score of less than 48 from the last 3 days, and the reflexes and the tone were decreased. So these were the lab reports which showed improvement in the renal function, and the blood and tracheal culture sensitivity came out to be negative, and similar antibiotics were continued because of the presenting and new organ dysfunction. So we planned for an exit and weaning, and we encountered a problem. The rest all parameters were normal, but we encountered a problem here, that was generalized muscle weakness that was present. So what can be the reasons for generalized muscle weakness in an ICU patient? Nutrition, yes sir. So diffuser we can give. Yes sir. So this is the malnourished and sarcopenic patient. This can be condition in an ICU patient who is bedbound for so many days. So systemic inflammation, sepsis, prolonged immobility, hyperglycemia, corticosteroids use of neuromuscular blocking agents. These are some of the causes which can be possible for muscle weakness. So for assessment of ICU acquired weakness, we did an MRC score which was suggestive of poor muscle power, and we performed a diaphragm USG which showed poor thickness and excursion suggestive of loss of diaphragm mass. So this is the MRC scale, that is the Medical Research Council scale. There are 6 group of muscles which are tested, 3 in the upper limb and 3 in the lower limb, and they are graded from 0 to 5. A total score of 60 is, there is a total score of 60, and a score of less than 48 is suggestive of ICU acquired weakness. So on day 4, 5 and 6, the patient's MRC score was 32, 34 and 34, which showed ICU acquired weakness. So this was the USG diaphragm that was performed on our patient. So the first image and shows a normal excursion of more than 1 centimeter of diaphragm, where in our patient in the panel 3 the excursion was less than 1 centimeter, showing ICU showing diaphragmatic loss of diaphragmatic excursion. So coming down to the picture, we were stuck with 3 failed spontaneous breathing trial attempts, and it came down to difficult weaning. So the events encountered on day 7, the sensorium improved, but ICU acquired weakness persisted, and we planned for bedside percutaneous tracheostomy. So this is what we do for the management of ICU acquired weakness. We should keep a intensive glycemic control, minimize use of corticosteroids and neuromuscular blocking agents, minimal sedation protocol, timely electrolyte replacement, optimized nutritional support, and collaboration with the PMR for advanced rehabilitation strategies. So now I'd like to call Dr. Devanshi Nayak, first year MD resident from the Department of Physical Medicine and Rehabilitation, to take us forward through the case.
Muscle weakness is acceptable.
Yes, sir.
But the picture shows muscle wasting.
Sir,
so my
yes, sir.
Let me complete.
Yes.
This is for all students. Don't, in the flight, when the announcement is made, the audio goes off. Same should happen in the class or in the exam. When the teacher or examiner is talking, you should stop talking. So I want to know what was the nutritional support given to this patient during the hospital stay with us and in the previous hospital.
Sir, the protein supplementation that we gave was 1 gram per kg per day, and it, as it was a catabolic state, so and ongoing sleds were also there, which in which there are protein loss, so we increased it to 1.5 to 2 grams per kg per day.
But he is 30-year-old, 35?
35, yes sir.
This picture in a 35-year-old, unless he had some pre-existing disease, which apparently he did not have,
yes sir,
means that the nutritional support probably was not adequate. And I want to highlight this point.
Sir, this is not the not our patient. It just sarcopenia.
So
here.
You are doing what the news channels do. Then you should say this is a representative.
This is very wrong. This is very wrong.
Why should you present another patient's picture? You
Sir,
could have presented this patient only.
happen in the ICU.
No, that is all right. Here we are, this is CCR, combined clinical round. So you have to discuss that case only. Don't cite examples. In the discussion you can cite these examples, not in the case.
Because
it
the
was very
picture-
confusing to me also.
Picture cannot show muscle weakness. Picture can show only muscle wasting. But I wanted to highlight this point that all of us, when we are treating patients, we get so involved with investigations, invasive procedures, drugs, that we forget nutrition. We have a very proactive dietetics and nutrition department. We should make use of their presence and their expertise. And every patient who has a pre-existing nutritional deficit or has a prolonged hospital stay, nutrition must be taken care of.
So one question. We are here to do the combined rounds for the critical analysis,
Yes, sir.
introspection, and discussion with other departments. We should be very honest in our approach. That is how we can follow.
So, what are the features of critical care myopathy and critical care neuropathy? So, you have not included this in your list.
No, sir, we have kept it in the differential line. Yes, sir. It comprises. Yes, sir. It comprises of critical illness myopathy as well as critical illness polyneuropathy also, sir. The muscle weakness.
Thank you, Dr. Sankal. I'm Dr. Devanshi Nayak, first-year MD resident from the Department of Physical Medicine and Rehabilitation. The history is already noted. We received this reference from the critical care team as the patient was already on day 7 of ICU admission and day 16 of respiratory support and had difficulty of weaning. We did detailed assessment of this patient in which motor power we could assess was very low. On MRC scale was 34 and consistently for 3 previous days. In addition to that, patient was not able to protect airway, so it was on tracheostomy. His breathing pattern was poor and ventilator dependency was present. The functional assessment state was also poor. He was bedbound with minimal mobility and not able to sit, stand and walk, and he requires the assistance for all activities of daily living. So we approached this patient by multiple approaches. The neuromuscular electrical stimulation applied to muscle to be strengthened on alternate day for 15 to 30 minutes. Respiratory muscle training with the help of incentive spirometer and chest physiotherapy daily 4 times by a physiotherapist under the supervision of the PMR. Muscle strengthening and range of motion exercises 2 sessions per day for 5 days a week and gradually increase in intensity and duration of a session. Positioning, splinting and range of motion exercises for the prevention of contracture. The tail table for orthostatic tolerance, it started at 0 degree, then gradually increased in 30 degree, then 60 degree and progressed to 90 degree over a 1 week and held for 30 minutes per session. Functional training with mobilization to chair and supported to work to improve the activities of daily living. By all this intervention and supportive care that we provide to his muscle and then his muscle power improved to MRC score of 36 to 48. Respiratory function also showed the muscle strength of improvement and weaning was successful afterwards. His functional status also improved after he could able to sit without support and able to perform activities of daily living with assistance. And I would like to call Dr. Sankal.
I would like to inform all of you that please involve Department of PMR, Physical Medicine and Rehabilitation, as much as possible. We are planning to have a separate institute of physical medicine and rehabilitation. All the department, I request that those who have the chronic patients immediately contact or with the Department of Physical Medicine and Rehabilitation.
Thank you. We'll move forward with the case. So on day 8 to 14, sequential weaning was planned and the patient was taken to portable ventilator support and it was provided intermittently and started for 18 hours per day. The CNS, the GCS improved and generalized weakness with an MRC of 46 from the last 3 days and reflexes and tone were yet diminished. This was the investigation panel and the PCT came down to 0.6 and we de-escalated and stopped all the antibiotics. From day 15 to 20, the portable ventilatory support provided intermittently, now only during the night time for 4 to 5 hours. The MRC score had improved from 46 to 48, and neck holding was present, and the patient was able to hold sitting posture. So we finally decannulated the patient on day 17, and he was shifted to ward on day 18. Rehabilitation care was continued from ICU to ward and to home. So the advice on discharge to this patient was that intermittent hemodialysis 2 times per week to be continued at home at native place, and in case of any problem he could consult the Department of Nephrology at Mahatma Gandhi. Continued limb and respiratory muscle strengthening exercises, adequate nutrition to regain weight, follow up every 15 days, a G6PD deficiency analysis to be done after 2 months, which also showed low activity, and to avoid the drugs which could precipitate.
Can you just show the drugs for us also, for general?
Yes, sir.
For our awareness, sir.
Thank you, Sankalp. So it was a pretty complex case, I believe. But why did we choose this case? So dengue with acute kidney injury is a significant and often lethal problem, sir. Global studies consistently report mortality ranges between 25 to 32%, along with substantial burden of residual organ dysfunction. However, data specific to our region is largely deficit, and no such study is present in Indian population and North Indian population to be specific. So recognizing this gap, we conducted our own study last season of dengue. The results were in the line with the global data. It is showing similar high fatality rates in dengue and acute kidney injury. Importantly, our study demonstrated that SOFA score at 72 is the most robust predictor of identifying net negative outcome in dengue patients with acute kidney injury. This paper is now under consideration in a reputed PubMed index journal. And adding to that complexity of this case, several challenges were there. G6PD deficiency and hemolysis were there. Metabolic encephalopathy and profound ICU-acquired weakness was also there. It was only through early recognition and timely intervention that we were able to salvage this patient, sir.
So Ravi, can I interrupt?
Yes,
I
sir.
think the predominant contribution in your case to the AKI was the intravascular hemolysis.
True, sir.
And the G6PD deficiency producing that. And dengue was probably not contributing or a secondary contributor.
True, sir.
Right?
Sir, actually, ICU-acquired ICU syndromes are like that, sir. We cannot be totally sure all the time. Patient was having dengue, prescribed aceclofenac and paracetamol for fever prevention. That might be contributing to. So, multifactorial reason for kidney injury can be there, sir. But truly said, sir, largely contributed by pigment-related nephropathy. But the management remains same largely.
And chloroquine is most of the times co-prescribed with primaquine, so it can be a culprit.
Yes, sir, but as we had the history, chloroquine was there in the list of the general practitioner. Yes, sir. XLR, sir.
Genetically or sporadically. So it's such a common dengue with chloroquine and primaquine. Are we advised family for screening, because it's a very common X-linked recessive 25% chance in the other family members?
That was done in follow-up, sir.
All other family members should be screened for that and advise them to avoid these medications.
True, sir.
Is sporadic. Your case is sporadic or genetic?
I believe, sir, Dr. Naveen will be better person to.
PD is the main culprit. And it's a common situation, as you are telling, 30% of the is there.
I'm not aware of the patient's family's testing reports. I have not seen the patient in the follow-up. So we do advise
General question, are we advising such a common disease which occur with such a high incidence with a common medicine? It's advisable to give the family members also.
So whenever a genetic
Problem is there, yes, sir.
diagnosed, depending on the inheritance, the relevant family members have to be screened. So the same is true for G6PD. At the same time, your conclusion was that the patient was having a severe G6PD deficiency. So how come in the past 35 years, since he didn't have any episode, the past is totally asymptomatic, he might have received some of the incriminating drugs that have been listed.
True, sir. But the history was reported by the patient, so we cannot help
he
it.
can be healthy throughout 35 years. Why?
We cannot be
I
like.
think it is the dengue which has precipitated
So the
all these things.
history is given by the patient. We cannot just fight with them. True, sir. So. So, to successfully liberate these kind of patients from ventilator, discharge them from ICU, eventually send them back to home requires sustained high level of care, teamwork, and unwavering motivation. It all needs a team. Actually, I would say it all needs teams. So, on behalf of Department of Critical Medicine, I would like to extend my heartfelt gratitude to our Emeritus Chairperson, Dr. Swankar sir, and entire management of the MGUMST for their constant motivation and providing top-class teams at this institute, sir. To the CCR Review Committee, Dr. S.S. Jaiswal sir, Dr. Hemant Malhotra sir, Dr. Lalit Sharma sir, for their rigorous support in helping us prepare and refine this presentation to this stage. To our collaborative department, Department of Clinical Hematology, Nephrology, Radiodiagnosis, Neurology and Physical Medicine and Rehabilitation for their unwavering support in managing this case. To all other teams involved in the care of our patients for their continued effort and cooperation, sir. And most importantly, to the patient and his family for consenting to share this case on this platform, sir. Finally, I would like to express my gratitude to the Almighty God for giving us a strength, wisdom and opportunity to be His humble servant, sir. Thank you so much.